Hi everyone, and thank you, Lisa. We're happy we get to spend the next hour with you, and we're grateful for the opportunities that Dr. Brown provides for the entire healthcare team like this to learn together. For the next hour, we're going to discuss the very pivotal time of transition for an infant requiring NICU admission. Our disclosures are as follows. We are co-owners of Engage, Grow, Thrive and co-developers of the Small Baby Care Specialist Program. Mindy's a faculty member for Vaughan NICU Collaborative, and I am a clinical consultant for Dandelion Medical. Our objectives are as follows. We want to discuss 2 care practices that occur during the golden hour, list 3 potential gaps of premature neonate experiences during the golden hour and or the admission process, and then finally list the 4 elements of a PDSA cycle. How many of you have attended a premature infant delivery or have assisted in admitting a baby into the NICU? If we were together, we would just love to see how many hands are being raised. It's a sight to see for sure. It's an environment filled with different team members. It's a busy time with a lot of people caring for the mother and her baby. The NICU team often knows what to expect and plan for. However, the family, it can be really overwhelming. All they see is their baby looking small in the hands of strangers. They expected something so different. So is there something we can do as a NICU team to make this experience better for the family? Today, we want to focus on that first 60 minutes of life called the golden hour. We know that every experience a premature infant enjoys or suffers has lasting impact. So how does the interdisciplinary team provide the best care during this first hour? How do we create an environment that sustains life while promoting healing and minimizing the impact that the delivery room and NICU admission process has on that tiny baby's developing central nervous system? We also want to challenge the NICU team to do what they have to do while also thinking differently, bringing in other healthcare team members and perspectives to enhance the standardized work of the golden hour. We're going to encourage the team to not get stuck and to get off the escalator. Watch this and see what we mean.
Whoa, that's not good.
Oh, I don't need this. I'm already late.
Somebody will come. Anybody out there?
Do you have a phone?
No. Sorry. Somebody! Hello? There are 2 people stuck on an escalator and we need help. Now, would somebody please do something? I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, there's not enough left to do, is it?
Hello? Hey, don't worry about it. I'll fix it in a second.
He said he could fix it. All right. All right. That's more like it. He says he can fix it.
Kind of a silly video, we know, but it definitely makes a good point. Care provided in the delivery room and during an admission process is necessary. However, it creates potential problems for the infant. So how can we get off the escalator, having to perform required practices, yet think and do them differently? Let's start with the golden hour. Mindy's going to take us through that period of time, and then we'll discuss the admission process and how quality improvement projects and processes can incorporate the interdisciplinary team in collectively bringing neuroprotective care into this pivotal period of time.
So let's begin with the discussion of where the term golden hour actually derived. It's been found that the first hour of care after an event predicts survival and outcomes. And the term golden hour actually historically began with the military in combat, where those that were in combat, if they were injured, depending on how quickly they received care in the field and then how quickly they were transferred to a military hospital, that determined their survivability. That term is then translated into our care in the emergency department and in healthcare in the United States and elsewhere, where the care is also related to not only trauma, such as motor vehicle accidents or other types of trauma, but also myocardial infarction or cardiac care, and then stroke. And research has also shown us that what happens in the first hour of life of the preterm neonate delivery can lead to both short and long-term consequences. It affects neurodevelopmental status, and it has a higher risk of death. So this care, this concept is certainly applicable to the care of the preterm neonate after birth. Regardless of where golden hour care is occurring, there are a few overarching concepts. One is that it requires an expert interdisciplinary team, and these team members are not only expert in their technical skill and their knowledge and their training, but they're also expert in the skills of communication and collaboration. They have an understanding that the value of communication is going to be so important in achieving their goals of good clinical outcomes. Another concept that it includes is the application of evidence-based practices. And then it's been incorporated using tools to achieve standardization or reliability in practice. So you have that consistency in practice. And these tools help not only standardize practice, but they also can help standardize some communication as well. So just think for a minute about the other periods of golden hour care. Trauma, myocardial infarction, stroke. These are all acute changes that are occurring in a person that has a presumptive normalish physiology. Birth, however, is a complete change in physiology. The transition from a dependence on maternal and placental provision of circulation, oxygenation and gas exchange, and nutrition, they transition to an independent neonatal supportive physiology. So just talking about those few physiological aspects, circulation, which has occurred via the placenta, and that is a very low vascular resistance system. Now, after birth transition, the cardiovascular system becomes continuous, and the cardiovascular resistance increases, and cardiac output also increases significantly. Oxygen and ventilation, which have occurred in utero, now must occur in a pulmonary system that is air-filled or gas-filled rather than fluid-filled. So the lungs must now initiate function and ventilation and oxygenation. And then the last system, metabolic, as the fetus, thermoregulation has been consistently provided by the uterus in the mother. Now the newborn must maintain their own thermal stability or maintain it with the assistance of healthcare providers. And there's also, as a fetus, a constant stream of fluid and nutrition that's been provided. As gestation progresses, during that third trimester, there are deposits of glucose, fat, and protein stores to be used for energy. Again, that's during the third trimester. So the term newborn has these stores to tap into as they await nutritional delivery. The preterm neonate, however, has no stores to rely upon. So due to this complex physiologic transition, the term golden hour is an appropriate term to be used for neonatal adaptation. The foundations of this work really began with the development of the Neonatal Resuscitation Program, or I'll be calling it NRP, and that was developed by the American Academy of Pediatrics to focus really on improving delivery room care, as they identified that it was a high-risk situation. The first NRP training occurred in 1987, and I can say, and I think I can speak for Liz, and acknowledge that we were both working in NICUs at this time. During the last several decades, there has been extensive evolution of NRP. The goal is survival without the initiation of the morbidities that these babies are at risk for in the NICU, such as intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, retinopathy of prematurity, and pneumothorax. The focus is on the ABCs, so airway, breathing, circulation, plus thermoregulation. And an hour, if you think about it, an hour in the care of these babies who are in our NICUs for months, an hour seems like a very short period of time. However, in this period of physiologic adaptation, so much is happening. And I specifically chose this picture of the hourglass with the grains of sand, as I think we should visualize golden hour as a slowed down process. There was a publication in Neonatal Network in 2012, and it was called 60 Golden Minutes. And I really like that focus on minutes because, as we know, as we work in NICUs, every minute of every day for the preterm neonate makes a difference on a lifetime. There is so much that goes on in the delivery room. So many interdisciplinary team members, so many necessary interventions, so many hands. In this slide, we'll review some of the steps and how NRP steps have evolved over time for the preterm neonate. And all of these evolutionary changes are based upon evidence-based practices, and many of them advocate for a gentler approach. We'll talk about airway first. Previously, an airway meant an endotracheal intubation for most babies that were born at less than 1,000 grams. However, as neonatal respiratory management in the NICU transitioned towards non-invasive therapy and support, this is now included in the delivery room management as well. And many more babies are managed in the delivery room receiving CPAP support rather than intubation. For breathing, apnea or poor initiation of respiratory effort is not uncommon. Also, a slow rise in the heart rate is not uncommon in the delivery room either. Both of these conditions may require the support of breathing, and the recommended step to support breathing is positive pressure ventilation. Now, previously, positive pressure ventilation was given using a bag and mask if the baby was non-intubated, or a bag and the ET tube if the baby was intubated. But methods of providing positive pressure ventilation have changed, and they have become more consistent with the use of a T-piece resuscitation. The second part of breathing is oxygenation, and oxygen is a drug, and oxygen toxicity has significant impacts on long-term outcomes like retinopathy of prematurity. Previously, 100% oxygen was utilized in the delivery room, and now oxygen in the delivery room is blended, so there's titration of oxygen based on the needs of the baby and what their pulse oximeter is reading. Circulation includes not only an increase in the heart rate to over 100, but also stabilization of blood pressure. And in the last few years, this has transitioned to include delayed umbilical cord clamping. And this improves not only blood pressure, but it reduces the need for blood transfusion, and it's been shown in research studies to reduce the risk of all grades of interventricular hemorrhage. The last category is thermal stability. And when you think about the A, B's, and C's, thermal stability doesn't seem like it has the same importance. However, hypothermia increases the risk of respiratory distress syndrome, NEC, and IVH. And hypothermia has been identified as an independent risk factor for mortality. We've been given great supplies to add to our care in the delivery room to help thermal stability with caps, pre-warmed linens and nests, and polyethylene bags or wraps. As NRP has evolved, it's also identified that safe, reliable care goes beyond the clinical interventions, and the program has evolved to include communication strategies and incorporated those into recommendations. All interventions are based upon best evidence, including the communication strategies. The clinical interventions that are recommended in the delivery room must be performed quickly and proficiently by an interdisciplinary team that possesses not only those technical skills, but they also have communication and team-based skills as well. And to support not only the technical skills and the clinical skills, but also to support communication skills, use of protocols and bundles of evidence-based practices that standardize that application consistency is recommended. This includes communication during the golden hour. An example of these tools are checklists, algorithms, and then the use of briefs prior to a delivery room situation, and then debriefs afterwards, which actually debriefs the team's performance. So here are a couple of examples of tools to support teamwork. They also identify roles of the team and expectations of the team and expectations of communication, which is really important. They ensure that briefs occur prior to the delivery and that debriefs occur for the team to self-review post-delivery. Incorporation of these types of tools are found in many publications. So if you're just getting started in this type of a process, there are a lot of publications out there that have examples of tools that you can pull from and see what works for your unit. You know, a checklist is one great tool, and another one is a flowchart. And this is an example from one publication. Again, there are many of these in publications that you can use to get started. You can see in this example that the tasks are listed by roles, and the roles may change depending on your unit and the team members that you have that attend deliveries. In this one, in the first column, it's the role of the NNP. In your unit, that may be a physician, or it could be a physician's assistant. There's also the role for the RN, and on the far right, you'll see a second RN. For the extremely preterm neonate, a lot of delivery teams include 2 registered nurses. Now, sometimes that second registered nurse may be an OB nurse rather than a NICU nurse. This example has a column for 1 RT. Some teams have 2 respiratory therapists that attend delivery. So depending on what your team membership is, you can develop this flow chart to match that. And you'll also see on this flow chart that it begins at minus 10 minutes prior to the delivery. And many of the flow charts have that as an example. And I think that that's a really great step to include because it allows you to prepare. If you want to take that a step further, you could even back that out to a minus 24 and have the opportunity to talk to the family ahead of time, talk to the OB team ahead of time, and really come to a shared mental model on what this delivery is going to be like. So you can see that there has been an overwhelming physiologic transition that occurs with the birth of any baby, but especially a preterm baby whose physiologic systems are not ready to take on some of the roles that now they must. There has been tremendous improvement in delivery room golden hour care, and all of these are supported by evidence-based practices, and this has occurred over the last couple of decades. Golden hour delivery room care continues to be a very frequent focus for NICUs for a quality improvement project because they're very high risk and there's lots of opportunities for improvement. So despite all this progress, are there major gaps in care in the delivery room that still persist that we can address? Well, we've acknowledged the overwhelming physiologic transition that's occurring. What about the neurosensory exposure that's also changing dramatically? As we know it, the intrauterine environment is the perfect environment. It's controlled and predictable. It's warm. It provides containment. It provides protection. It's always teaching the fetus about itself, and it's providing that quieting and self-regulation that the fetus yearns for. So contrast that with the environment that the preterm neonate is in following birth. Now they're in an environment that is no longer dark and fluid-filled. It's not a supportive environment. They feel gravity for the first time, and they're completely exposed. And the gravity that they feel is not only their own weight as it sort of sinks into the mattress of the radiant warmer, but it's also the gravity of all of the equipment and supplies that are touching them or being attached to them. The environment is often loud and bright. There are many hands moving very quickly and touching the baby all at once. It's also a very invasive time, and unfortunately, most of that invasiveness may be necessary. However, how are those tasks being completed? It is about what's being done, but it may be more about how is it being done. So some gaps that we see in the delivery room are, how do we keep these images of the intended environment in mind when we're performing sometimes life-sustaining interventions? It's about incorporating neuroprotective care in the beginning of the delivery room. So optimizing the environment, limiting exposures to cold surfaces and equipment, making sure we're using the appropriate lighting for our work to be completed, but limiting the baby's exposure to light. Reducing noise. Now, that doesn't mean that there is no sound. The team must communicate, but it does mean to try to decrease noise. So doing things like avoiding loud talk or loud conversation over the infant, making sure that the monitors are not too loud. Now we have much more monitoring equipment in the delivery room than we used to. And remember, the obstetric team is a part of this environment as well, so they also have to be on board with the same practices. It's about putting the baby in proper positioning from the start, nesting the infant in a proper containment with a slightly flexed position in the head midline, trying to be cautious that we're not overhandling the baby. Some NICUs have actually moved towards one caregiver providing hands-on containment during this time frame. And wouldn't that be perfect if that was actually a parent? So making sure that we utilize this fantastic equipment that we have to bring into the delivery room as far as supporting positioning, but also keeping in mind that using that equipment can provide some nurturing touch by putting the baby in a position where they can self-soothe and touch themselves. But remember, nurturing touch can also be provided by a healthcare provider. So these all support both neurosensory protection and physiologic transition because it decreases the stress and it decreases the metabolic workload.
Now, once the infant and team is out of the delivery room, the golden hour continues. The infant has just experienced something likened to what a trauma patient experiences. The care that happened in the delivery room is often very sequential and standardized. Now, depending on where the baby is delivered, there's another change in environment that the infant is asked to endure, and it's not always streamlined or predictable. This phase of care is transport to the NICU. No matter where the baby goes next, there's an immediate separation. The healthcare team does their best at ensuring the baby is brought to the mom so that she can touch and see her infant. However, we don't always realize what other things are involved in separation. I love when we get to meet outside of our NICUs like this. We get to remove ourselves or separate ourselves from the immediate responsibilities, and we get to reflect honestly, we get to think critically, and we also get to think collectively to see things differently. So let's look at what the infant experiences next. This team continues to transition this infant from the familiar and safe intrauterine life through another required dynamic yet stressful process. Not only is the infant continuing to move through a physiologic transition, but now we layer a transport and an admission process. What does that look like? Some infants are transferred to another hospital via ambulance or helicopter or fixed wing, which brings a totally different set of experiences. Bumps of the transporter, the drive, thermal challenges, because remember, we're moving this baby from mom to a warmer for resuscitation, then to a transporter, and then again to a new incubator when they arrive at the receiving hospital. What does that all feel like for this infant? If the infant is able to remain in the birthing hospital, the transition is definitely a bit easier for the infant. However, you can see how different the infant looks in this new environment. To the healthcare team, this looks perfectly normal. What does it look like to the parents seeing their infant wrapped in cellophane, laying flat with a tube in their mouth and wires attached all over their body? We can only imagine the thoughts and emotions they're experiencing while the team takes their baby away. There are a few things that are important to look at that don't come to the forefront when we separate the baby from their parents. The first is lack of microbiome seeding. Many premature infants are delivered by cesarean section, which disrupts the mother-to-infant transmission of important bacteria, which increases the risk of many diseases later on in life. The cesarean birth, as currently practiced in most U.S. hospitals, has additional implications on neonatal microbiome seeding. In a cesarean birth performed under epidural, newborns may definitely experience skin-to-skin contact with their mother following birth, but in an urgent or cesarean section of a preterm infant, they would not experience immediate skin-to-skin. What they do experience is being handled by the healthcare team, plastic, their skin is touching various operating room and recovery room surfaces. We do know that premature rupture of membranes may help seeding. However, the infant isn't exposed to the vaginal microbiome unless they are born by a vaginal birth. Another important process that gets missed during the separation is thermoregulation. In a normal term birth, an infant is placed on the mom's chest, which is not only the benefit of the transmission of microbiomes, but the sound and the vibration of mom's voice and warmth of her body. All of this helps the natural transition from intrauterine life to extrauterine life. Studies have shown that when skin-to-skin occurs, there's an immediate maternal thermal response to her infant. The tactile contact elicits this maternal adaptation and warming of her infant. It's thought to be caused by a maternal autonomic nerve-mediated skin vasodilation and maternal control over the amount of breast heat that's conducted to her infant. However, for a premature infant, that doesn't occur. When there's a physical separation from the parents, especially the mother, there's an emotional and a social separation also. The familiar sounds of the uterus that created history for the infant are now gone. They're not only cut off by the birth process, but now we take them to another geographic location away from the internal and the familiar sounds of the parents to an environment of foreign sounds and voices. The baby is now being exposed to noise. We've all seen a NICU admission environment before. I have to laugh sometimes. It's like you know an admission is happening when you see more people around a bedside than there are limbs to the infant. There are bright lights that are needed for required assessments of color and perfusion and skin integrity. Lights may be needed for IV placement and line placement for the physicians or nurse practitioners. There's also a lot of noise. There's transitioning of monitors and leads that cause alarms to sound. There's noise from equipment, and most of all, there's noise from conversations and orders being called out. Listen to this for a moment.
I want to try and get that thing that's left on her eye. I'm nervous. You can't see it right now, but when she was opening. Oh no. Gotcha. There you go.
What did you hear? I heard calm and quiet voices talking to the infant, yet the competing noise heard in the background was louder than the sound of mom's voice, which was familiar. What does it do long-term when the white noise is louder than those salient sounds of the spoken word? We know that it later disrupts verbal acquisition. Another noise concern during a NICU admission is the amount of activity that happens in the rest of the unit. Everyone who is working that day seems to want to help. We're great team players, right? But when that happens, what's happening with the other babies in alarms? Who's tending to them? Like in the audio, we heard a lot of noise directly at the baby's bedside, but not all those alarms were from the infant, and they still can be disruptive. What does the admission experience look like and feel like to that infant? We're such a task-ridden society, and we see it more and more in our NICUs every day. The admission experience is very procedural in nature. It's very fast-paced in nature. The tasks required are often in some sort of mental checklist in our minds. But do these tasks just become something to check off? If we were to reframe those tasks, would we do them differently? Could we do them differently? When we take a temperature, for example, instead of putting the probe under the baby's arm and moving to something else quickly just to get it done, can we be still and maybe assess their resting posture or movement patterns? When we're starting an IV, can we reframe the experience and instead of thinking, let me just get this IV in while dad is watching from the chair next to the bedside? Or can he be the one to help with facilitative tucking, or providing the sucrose with the pacifier, or quietly consoling his baby? One area that I think we can rethink is the timing and necessity of some of our measurements. Are chest and abdominal circs necessary on admission? These two measurements require increased movement of the infant, and especially the ELBW baby, and movement into space. Are 4-point blood pressures necessary on admission? If you have an arterial line for blood pressure measurement, is a rectal temp necessary? We should ask ourselves and our teams, why do I do such and such? And what do we do with the information? Most all touch during the admission is procedural. There's hardly any relational touch going on. We place them in positions for procedures that are an extension versus physiologic flexion. Instead of the smells of amniotic fluid and their mother's skin, they're chemical smells. They're often under an overhead light for procedures. There are chemical and toxins being placed on their fragile skin instead of maternal microbiomes. What we put into and on the premature infant has epigenetic effects that can alter gene expression later. Our infants don't have the ability to verbally speak, but they have cues both behaviorally and physiologically that they use to communicate, and they communicate very well to us. There's so much being done to them, but what are they saying to us with their cues? Are we listening, or are we busy performing tasks? What are the gaps between what they would be experiencing, and how can we stand in that gap and do things differently and bring in another perspective to those experiences? Let's identify the gaps and talk about them for a little bit. We know that neonatal stress is greatly intensified by maternal separation, exposure to repetitive and stressful caregiving interventions, painful procedures, and unfiltered noise and light. We know that short-term stress can increase their energy expenditure and increase their cortisol levels, causing more cardiorespiratory instability, complicating this important transition from intrauterine to extrauterine life. If we begin to decrease stress as early as the golden hour, can we help the infant's capacity for improved neuroplasticity by minimizing the earliest of stressful experiences? So what can we do? Let's talk about mom first. One way that we can bring her into the history and bringing history to that baby is by including scent cloths or lovey dolls as early as the delivery room for her to hold, so that wherever the baby goes, that maternal scent can be attached to that baby. What about dad? Can he follow the team? Can he be a calming voice for that infant or a calming hand? We developed a dad-to-dad video. A dad who had had 2 previous premature babies in the NICU just speaks to dads on admission and says, hey buddy, I know where you've been, I've been there, but you can trust this team. They will explain everything to you, but what you're experiencing is totally normal and you'll get through it. What about the things and the tasks that we do? What needs to be done now? Painful procedures place the infant at risk for intracranial pressure. Do we support these babies appropriately during these procedures that we have to do? How many people are at the bedside? Are eyes covered? Are people talking across the room or over the infant? Are other alarms going off? Does it take a few minutes more to provide a different experience? Yes, it does. We want to just get things done and get that baby tucked in. But at what cost? Can we take a moment and tell ourselves, don't just do something, stand there. Stand there and watch the infant. That's an important part of our assessment, is observation, and we forget that tool. Can we help that dad or grandparent just watch and enjoy the little fingers and toes and ask some normal things like, who do they look like? Who has his color hair in the family? When we have conversations like this, we're also building relationship and trust with that family. Now that we've looked at the golden hour and gaps, what can we do? We want all our teams to ask, what other team members can be our ears, our eyes, and our hands during this time? Is it the parents? Is it the developmental team? Can we have other team members who typically are not usually those that admit infants to observe and provide feedback? These roles can easily be integrated into the golden hour by quality improvement processes and projects.
We're going to talk for a couple of minutes about quality improvement in general, and then we'll use this foundation to suggest some additional practices that we might consider incorporating into golden hour care. So we've been in healthcare, especially in the NICU, for many years, and when we first started, QI was called CQI, for continuous quality improvement. But then somehow that word continuous was dropped. However, this is a really important omission. Quality improvement is a continuous journey. It's a continuous process. We, earlier in this presentation, identified the evolution of golden hour practices in the delivery room, and those were based upon evidence, and that evolution needs to continue. It's about identifying opportunities, then identifying the evidence to support practice change, and then implementing that evidence via a quality improvement methodology, with the goal always to provide safe, equitable care. One QI methodology that's widely followed in healthcare and in many NICUs is the Institute for Healthcare Improvement, or the IHI model for improvement. And you can see on this slide that really it's about answering several questions. Firstly, what are we trying to accomplish? So that sets your aim or your goal. Secondly, how will we know that a change is an improvement? So that helps direct the measures that you're going to collect, or the data that you're going to collect. And you're going to collect measures not only to show that you've made an improvement, but also to show that the new change hasn't caused any harm. Lastly, it's coming up with ideas, improvement ideas. What change can you make that will result in improvement? And that then sets you on your task of performing many tests of change, small tests of change, or the PDSA cycle, plan, do, study, act. So again, I think that this is a concept that a lot of times people forget about, and especially as you become really experienced in quality improvement, you sort of want to jump to, there's this great new study out, it shows this evidence on why we should change our practice this way, so we're going to make this change, period, that's the way it is, and you make the change. When really QI is about these simple tests of change, multiple tests of change. It requires these multiple PDSA cycles, and it is about the detail. So it's not about taking that single idea or that evidence-based practice and simply implementing it. It's testing small tests of change. So your first PDSA cycle may be on one patient. And with each test of change, then you make it better. You see what worked well and what didn't, and then you make it better for the next step. It may be using, instead of one patient, it's one provider, or you started on one day of the week. And then once you get your feedback and you make the next change to your process, you might say, hey, we're going to roll this out to day shift and start it on one shift. Or you're going to start it on in a certain area of the NICU. But it's about testing that so that when it comes time to actually officially rolling out the project, it's been reliably tested to achieve success. So these small tests of change are super important. And we're not going to, that's really the sum, the totality of our discussion on QI. If we're really going to get into it, that would be a full lecture in itself. But there are a lot of great, rich resources out there. Many articles that are kind of primers. But then IHI has a toolkit that's available that has all of these tools that are listed on this slide. So they're in a format that you can just download it and start using them right away. So in using QI strategies, how can we improve golden hour care from a developmental care perspective? And we'll first talk about golden hour in the delivery room, and then we'll talk about it in admission. And this isn't really necessarily a new concept. There was a publication back in 2002 in Neonatal Network called Developmental Care Considerations of Resuscitation of the VLBW Infant. And it called for implementing delivery room care, developmental care. Now we're nearly 20 years beyond this, yet these components have yet to be incorporated in NRP or yet to be reliably incorporated in many NICUs. Delivery room standards typically are driven by professional agencies to provide safe care or safety during resuscitation. And it seems like the mindset is physiologic goals, then developmental care goals. However, these are not mutually exclusive and they can be carried out at the same time. So it's not just about implementing evidence-based practice, but it's about how we implement that practice. So we're going to talk about some examples of some ideas that you might consider incorporating. So the starting point for any QI activity is to determine what opportunities exist. And I'm going to talk about really sort of what's the best way to identify an opportunity, but then we'll give some other examples as well. So the best way would be, can someone that has a developmentally supportive care perspective observe several preterm deliveries in an effort to identify some opportunities? So maybe observe 3 to 5 deliveries. Can those deliveries be video recorded so that you can debrief afterwards? Now, many teams, as a QI activity, are starting to record their deliveries, and then they debrief those videos, but they're debriefing them to discuss about team performance and really probably looking at more clinical outcomes. Can you use those videos as an opportunity to identify some developmental care opportunities? Oftentimes, if you have somebody that's able to observe practice, they don't have any clinical responsibilities. They're simply there to observe. It provides so much insight into the opportunities that exist because that person's not focused on the task. They're focused only on the baby's reaction, tolerance, and cues to what's being done. So if observation is not possible, can you review some of these golden hour checklists or flowcharts that your team has developed? And you'll likely identify some opportunities there as well. So as an example, if you look at this flowchart, we talked about this flowchart earlier, and now we're going to just focus on the portion of the flowchart, the first 15 minutes that's in the delivery. In looking at a goal to make the delivery room a more neuroprotective environment, there are likely opportunities before the delivery to improve the environment. That time frame, that 10 minutes when you're getting everything set up. And you can see under the admitting nurse column, they have about getting supplies, warm blankets, the thermostability wrap for the baby. Doesn't mention anything about dimming the lights and eye covers. And I think those are two important components to include. And I'll also mention here, and I didn't mention this earlier, I really like the idea that on this specific flow sheet that they have the admitting nurse in the delivery room. That lessens one transition of care. You have the nurse that's going to be taking care of the baby the rest of the shift in the delivery room as well, starting that continuity in care. If you look at periods of the 0 to 10 minutes, when the baby is delivered, makes its way to the warmer, and has all of those multiple hands of caregivers providing the care that the baby needs, we can also make sure that lighting is decreased, that the handling is limited, it's not overhandling the baby, that there's some nurturing touch provided as well as the procedural touch. But putting the baby in a position of comfort and certainly covering their eyes from the bright light of the radiant warmer. And then in that last column there, which is the time frame of really making sure the baby's stable for that transition to the NICU for the admission process, but lowering the alarm volumes if possible. Some units have even incorporated the second RN monitors the alarm, so the alarm level is very low, and they're identifying any needs that the team needs to be aware of. And then again, that position of comfort so that the baby is in a position that is more what they were accustomed to in the womb. And certainly family presence. If mom is unable to have any time with the baby prior to transitioning to the NICU, certainly mom's partner having that opportunity.
So let's go back and look at the admission process and what opportunities for quality improvement there might be. I think the first thing we need to ask our teams are, do we have guidelines with roles assigned and delineated for admissions? We know that in the delivery room things are very structured and they're very standardized, but our admission processes aren't always like that. Like we talked about, there's a lot of people that will come and want to support and help, but forgetting all the commotion and chaos that can come along with that. So do you have guidelines? And that's the first question. And what are on those guidelines? Is it a list of 10 things that have to be accomplished in that first hour? And then coming together as an interdisciplinary team and asking ourselves, what really needs to be done in that first hour, and can some of those other things be done at the next care time? So what are some QI ideas? And the first thing might be, what would a two-person or two-provider admission look like? Almost like two-person care. So you have maybe the bedside nurse performing the needed vital signs and some of the measurements that are necessary, like length and head circumference for the physician to initiate their history and physical. But can that second person be the respiratory therapist? Can it be the rehab specialist, whatever your unit uses, whether it be an SLP, a PT, or an OT? Can that role support that baby? If anybody knows how to create a calming and a neuroprotective environment, it's them. What about the parent? What a great way to bring the parent in. So the first idea would be a two-person admission. Maybe a second process to that would be doing a noise level pre and post that QI project. So perform decibel level readings right now, the way you currently do admissions, and then after you institute a 2-provider admission, maybe do your noise levels and see what that does to the unit as a whole. You might want to look at a tuck-in time. Now, not to rush your process, you don't want to rush a process, but a tuck-in time that says, we don't have to make this admission process be 2 to 4 hours, we can do it in 1 hour and do the rest later. But we think it's very, very important to start thinking outside the box, or as we saw, as if there is no box, and to kind of bring in other team members who might have a 30,000-foot view and can watch and bring some ideas and feedback from a different perspective. We know that teams are very creative. So we encourage us as teams to think differently, to think creatively, think critically, and not be afraid to change and get off that escalator. So we want to open it up to questions and answers right now. And thank you so much for having us with you for this past hour. And we can't wait to hear some of the questions and answers and ideas that are to follow. Thank you.
And several people are saying great presentation also, so just so you know. And I do have a question. If you, for therapists who are on and really want to get more involved in that admission process, but as we all know, that's very unusual, right? But how do they, what would you suggest that their first step is in getting in there when most of the time people say it's just for the medical professionals? What would you suggest that they start doing?
Well, I can start. I would say, I think Mindy and I both agree on this, is just if you can find somebody in your unit that is open, you know, in our unit, generally it would be the clinical nurse specialist or maybe a nurse practitioner who's open and has a very strong relationship with the therapy team, which we know is so vital. Just bring them along. In our unit, I would grab my my speech and language pathologist and I say, you know, Jen, I need your help. Can you talk to this dad about, you know, the importance of voice, lowering your voice, and the importance of his voice being history and things like that. And just kind of grab them and just bring them alongside and include them. And little by little, people will start seeing that and go, oh, we can do this better. I mean, usually our therapist is often a second care person, so why not during the admission process? So just get somebody, get a friend, phone a friend, and get them to come observe.
Great, thank you. The other question is there a preferred scent cloth?
Preferred scent cloth as far, I mean, I would say, you know, breast milk would be number one. But I'm not sure I understand the question. Preferred scent cloth as far as like a type of cloth,
I think that's maybe what people are asking. I know there are ones that are obviously commercial. I came from a unit where we made our own. So do you have any suggestions for that?
I do know that wool holds scent more than any other material. So creating something either with the head including wool, or this needs to have wool because that holds the scent more than anything.
Great tip, thank you. Someone says they have, their NICU has a golden hour committee and all are on the webinar. How long does it usually take to create this program?
How long does it take to create?
I don't know if they mean a golden hour program or even your small baby program, either or probably.
Yeah, I mean, I would think if you have a golden hour committee, you're already hopefully looking at some practices in golden hour time frame that you think maybe you have opportunities to improve even further. So, I mean, I think that's already a great start. If you have a committee and then you've got a lot of them on this as call, that you should have an opportunity to talk about incorporation of some of the developmental care practices in the golden hour. And again, I think it's not going to be, you go from 0 to 60 in 1 minute, 1 day, 1 week. It's going to be a slow process, but the first part is the openness, especially if you have a committee to talk about that is a part of care that tends to be lacking in the delivery room, especially that during admission. And if you're actively involved in providing that care in the NICU, it just seems common sense that actually starts to begin in the delivery room as well.
Laura, a lot of great questions come in, so we're going to keep going. We have a few more minutes. I know that the concept of having dad present in the admission process is very, we can't even imagine, right? But I love how you said, don't even think like there is a box. And so if somebody said having parents at the bedside during the first hour seems hard, and that's because we've never done it, right? But if they observe from a few feet away, would that be helpful? So are you saying that they should really be there or there?
Both. I think it's important, and I know sometimes NICU's resources are hard. So one way that we find it helpful is somebody else on the team, and this is why I love, thinking about the therapist. Generally, I do it when the admission comes in. We have the staff who's taking care of the baby because they need to focus, right? But having the dad actually right there, you can use it as a time to educate him on environment. You can use it as a time to talk to him about his voice. It could be a time to bring him in if the nurse is going to start an IV and just say, Dad, think about how your baby was inside mom, that strongest muscle, that uterus. Your baby needs firm touch. Can you keep his legs tucked in? You're also explaining vital signs. You're keeping him informed, you're keeping him occupied, you're keeping him knowledgeable, you're showing him, look at how active your baby is, that's a good sign. Or like I said, even talking about who has curly hair, it just bringing him in and calming him down, giving him information and having him not feel like he has to draw out, starts building relationship. And it doesn't matter who that person is that's talking with dad. It could be the manager, it could be the charge nurse, it could be, generally it's not going to be the bedside nurse or the physician because they're busy doing things, but the clinical nurse specialist, the developmental specialist. When you are a team together, understanding care together, and that's why Mindy and I always focus on interdisciplinary team. All team members should understand what that admission process needs to be. So bringing that dad in at the bedside and even holding the pacifier for sucrose and having that facilitated tucking, he could be the one to do that.
And I just want to add on to that. Again, it's not having a parent, a partner there immediately might be a challenge to go from no presence at all to that. Let's get them in the room first. So it's about making those small changes and starting to understand that they're a part of our team and that welcoming, because again, some parents are going to be uncomfortable at first. It's when we advocate for parents holding for heel sticks and they may not want to hold it first. They may want to provide containment at first. So it's about making those transitions so that the team and the family, everyone gets comfortable with that. But you have to start small. You have to just make one little baby step forward.
Great, thank you. And someone else just provided some extra information that one of the things they do is they do get their social workers involved right away at that time during the golden hour. So. Do you think an educational video regarding what golden hour delivery would look like is a good idea to show parents prior to birth, or maybe just to dad? Should this be situational? And well, you just addressed this in case it causes unnecessary anxiety. Good point.
Yeah. I mean, I think having those types of tools are great to show to dad, to partner to mom. I mean, a lot of moms want to know too. We know our dads tend to be more technical, but not necessarily. Moms may want to have all that information as well. So I think information is king. So if you have that available, I think that's wonderful. And then you know that there are some parents that's not going to be a good fit for. And just having that ability.
We have time for one more question, and then just so you all know, if your questions did not get answered, we will have Liz and Mindy answer them, and we will put all of the answers to our questions on our website when we post the recording as well. But the last question is, I think this could be a whole webinar in general, but a developmental one. But for NICUs, nurses, and doctors who are very far behind the times in understanding the benefit of a developmental team, what is your suggestions for their learning?
I saw that question in the chat, and I was hoping you were going to ask that one because I think that's a great question, and I wish there was an easy answer. I don't think there's an easy answer, and I think it's contextually driven depending on your team. But I always think, you know, people that work in NICUs have a science background. Science is the root of what we do. So there's really no arguing developmental science, right? Anatomical developmental science. So I think it's really kind of getting people to step back and think about that. And this is in the delivery room, in the unit, regardless of where it's at. You know, we have more and more studies that come out that are, you know, support developmental care, which is fantastic. It's not an easy randomized control trial, which is where the physicians live. So I think bringing them back to that kind of developmental science and having that understanding helps to kind of, you know, bring them in on understanding why that's an important part of care.
I'll just tag onto that. It also continues with building relationships, and that is about leadership, and we're all leaders. Every single person in our unit is a leader, and building those relationships, I think, is key. It's bringing people in that interdisciplinary team rounds and just say, you know, to each person, what do you think? What are you seeing? And little by little, that practice will creep. And all of a sudden you can start seeing this teamwork blossom, and you start hearing doctors say, well, what do you think? What do you think? And then you go, okay, we're getting this a little bit more. But like Mindy said earlier, you don't go from 0 to 60, but it is important to build relationship and then bring the science.
Thank you. I so agree. And, you know, as therapists, in a way, we're kind of in somebody else's nest, right? And so I think that it's so important to create that relationship and build before, you know, we come in and just want to create some change. That doesn't work that way. So right. Thank you. I just want to thank you both again for being here. I learned so much from you both every time. So I know our audience really loved this presentation. And we just want to thank all of our attendees for being here as well. Our next webinar will be in January. So please keep on the lookout for the announcement, and everyone have a great week and a happy Thanksgiving. Bye, everybody. Bye. Thank you.